Are you someone who looks on the internet and gets confused about all the conflicting information that's out there? Well, if you are one of those people, I don't blame you because I get confused myself. It is so overwhelming to look at this information about nutrition, about when to seek treatment, about IVF, about donor conception, about so many things. And there's so much conflicting information, it's hard to know what to believe. So if you're overwhelmed, if you're confused, if you just don't know how to think about your family building journey, we have answers for you today. You will meet an expert who will help you decipher what's helpful from what's unhelpful. So pull up a chair and focus because I think you'll really enjoy this episode. Welcome to Building Your Family. This is a podcast about donor conception, surrogacy, fertility, and all the ways a modern family is built. My name is Lisa Schumann. I'm your host. I'm an author, a researcher, a therapist, and I'm so excited to have you here today to talk to Dr. Sheeva Talebian. She is a wonderful, wonderful physician. She has amazing credentials, not to mention the fact that she graduated magna cum laude from a very highly esteemed college and medical school. She's also received many awards for both her surgical talents and academic talents. And she is director of the third-party reproduction program at CCRM-NY. But she and I met years ago when we were working together at a fertility clinic in New York. And since then, I have seen all of her amazing work and the magnitude of her intelligence, but also, for all of you out there, her big heart. She has an enormous heart, and you will see that in this episode. So I've asked her here today because I want to help you understand that there is so much out there on the internet that is so troubling and so confusing. And I wanted to bring in a big brain and a big heart to help us sort through some of these really tough questions that people struggle with all the time. So welcome, Dr. Talebian. I'm so happy that you're here.
Thank you so much, Lisa. So great to be here with you, and so nice to keep working with you throughout the years and sharing a lot of common patients.
Well, thank you. I really appreciate working with you as well. And I really appreciate your insight. And that's why I'm so glad you're here to talk to our listeners about some of these really troubling things that people are so confused about and they just don't know where to go. So the first thing that is constantly an issue, and I hear all the time, is I'm going through fertility treatment, whether it's with my own eggs or not, and I'm feeling like I really want it to work. And I don't understand why it's not working. And I'm worried that my doctor is not approaching my case with thought or with a big heart or with any concern about me because they're giving me the same protocol that they gave me in my last cycle. And I don't really understand that. Should I switch doctors? Should I wonder about what's right? Should I go on social media and ask these people who've been through it before if I should eat more pineapple? What should I do? I don't really know how to handle this tough situation.
I always say that my job is the easiest when it works right away, right? They come in, they freeze eggs, they get the number they want, or they're, making embryos, they get good embryos, first transfer works. That's where my job is the easiest. But unfortunately, that's a small part of what is reality, right? Unfortunately, it's not always a straight shot and it's not, a sprint. It's a marathon and it's an ultra marathon sometimes, meaning, unfortunately, we don't always get the outcome that we're desiring with the first cycle, even sometimes the second cycle. So what I always share with patients, whether it's, freezing eggs or it's, making embryos or even using donor egg embryos and transfers, if that first cycle doesn't really give us the outcome we were hoping for, let's meet, let's talk, let's sit and go through it. And what could we do differently? What can we learn from that round? So I always say we have to learn from the round that didn't give us the outcome we want and move forward. It's the only way to move forward is to learn from each cycle and try to tweak things, try to change things. Is there anything else from a lifestyle perspective or Eastern medicine perspective somebody could be doing? What else could we be doing in the lab? Are there any lab adjuncts we should be trying? Any changes in protocols? Unfortunately, I see it a lot. I get patients who come to me after a year plus of treatment at other places where it's really just been the same thing over and over and over again. and not getting any closer to the desired outcome. And, obviously, I always say I have the benefit of looking backwards and making recommendations. But I do think it's really important that if it's not working out for you and it didn't happen on the first cycle, that you actually advocate for yourself and you request a phone call or an in-person meeting with your physician and discuss what could we be doing differently. And it's hard to hear sometimes. And sometimes the answer is, we can't really do anything differently. We're doing everything
Mm-hmm.
we're doing, right? It's a really
Yes,
hard thing to hear.
100%.
And I always say, fertility medicine there's still so much we don't know and so much we don't understand. And sometimes we could be doing everything right, the clinic, the patient, and we still don't get maybe that positive pregnancy test or there is a miscarriage, right? And so, it's just a constant putting together the puzzle, and you really need to work with your team and advocate for yourself. And if you're not getting that one-on-one discussion, I do think it's time to get a second opinion. You don't maybe have to entirely switch clinics, but get a second opinion. And I see it a lot. Patients, I get it. They're on this journey with a doctor that they've been with for a while, and they'll say, they're not a bad person. They're not a bad doctor, but it's just not getting the answers I want. And there's this feeling of guilt if they want to get another opinion. And I'm like, you shouldn't feel guilty. I tell my patients all the time, if we're not getting the desired outcome here and we're trying a few different things, talk to other doctors, talk to centers that might do things differently. And, in the end, I want it to work for you, whether it's with me or not with me, I want it to work.
That's wonderful. So, could you explain to the audience a little bit why it wouldn't work? If someone is, let's say, kind of doing everything right and their doctor is doing everything right and it's not working, maybe the audience can hear a little bit about what are the factors involved here that could possibly be going wrong or where there's a mishap.
I think we can maybe focus specifically on like embryo transfers not working, right? Versus not getting enough, we'll talk about that first,
Right.
I guess, right? So, why is it not 100%, right? Why do embryo
Yes.
transfers sometimes not work? And, a couple of things. So in my practice, I pretty much exclusively do PGD testing on all of our embryos, autologous eggs, donor eggs, even. So really every transfer I do is frozen embryo that's thawed and then transferred, and they're all PGT tested. And, depending on the embryo grading and quality, there's a live birth rate associated with it. But, even at a CCRM with some of the highest rates, in the country, et cetera, even in the best case scenario, top quality day 5 AA blastocyst that's chromosomally screened has about a 70% live birth rate, right? The implantation rate's a little higher, but 70% live birth rate. So, what are some of the reasons why that embryo, why is it not 100%, right? And this is an area, this sort of like black box in our field that still we need to learn more and understand more. What I explain to patients, and unfortunately, when you do the transfer and you do your blood test and it's a negative blood test, it's not like we can go back and do like an autopsy on the embryo, right?
Mm-hmm.
Don't know. But still, so one, it still could be the embryo, right? Just because it's PGT tested and the chromosomes look like they're intact. There are other factors with embryos, metabolic factors, receptors on the embryo, receptors on the lining, so much that we just don't understand. So it still could be something with that specific embryo. And then patients get concerned, well, does that mean my whole herd of embryos may have something going on? And I say, no, it could just be something intrinsic to that one embryo. Secondary to the embryo, that now uterine factor. Are there polyps or fibroids that we didn't discover ahead of time? And this is, why always before an embryo transfer, you should have what we call an updated cavity assessment, saline sonogram and hysteroscopy or an HSG. If you had a prior miscarriage with actual clinical miscarriage, you should always do a cavity check before another transfer. So, it still could be something just anatomic that wasn't picked up. Hopefully not the case, because hopefully you're thorough or your doctor's thorough and that's been rolled out. And then it really kind of goes into this bucket of very sort of more esoteric, controversial, little unclear, is it a real thing or not, issues like autoimmune issues and blood flow issues, right? And this is an area where the literature is still a little cloudy. Literature, in fact, sometimes says, no, these are not real issues. But again, the literature is, the studies that are out there are not amazing, right? But it is, I think, something that I explore. If I have a patient who has a gorgeous embryo tested and it's just a flat out negative or a chemical pregnancy, even after the first round or first negative or first chemical, I do what I call an RPL blood panel. So it looks at antiphospholipid antibody syndrome testing,
Mm,
as well as inherited thrombophilias. And, usually it's negative, but I'm just like, okay, check the box. We did it, put it out of our minds.
yeah.
And, every so often I will pick up a real significant issue there. And, we refer to a hematologist and the patient may be put on baby aspirin and Lovenox or an injection blood thinner for their next transfer. Again, very, very rare, controversial. The literature says, no, no, these are not real things. Definitely, after a couple failed transfers or miscarriages, I would check it. But I tend to do it pretty quickly because it's just a blood panel. And, usually it's just flat out negative. But really it's embryo, uterine factor, or some occult, autoimmune or blood flow issue. I can tell you with confidence that it is not anything the patient did, right? I say it all the time. I'm like, it's not that you had a stressful day 3 days after your transfer, you got in a fight with your partner, you lifted your child at home, you ran across the street because a cat was
Hmm.
coming and you didn't want to get
Yes.
in,
Right. Right.
you didn't eat pineapple or you ate too much
Right.
pineapple, right? Like it is completely 100% out of your hands, right? Now, if you tell me we did a transfer and 2 days later you had very high fever, virus, the flu, okay, well, unfortunately, that was bad timing and there's probably didn't implant because of that, right?
Mm,
But even in that scenario, we do transfers and patients get GI bugs
yeah.
or COVID or the flu and they still get pregnant,
Yeah.
right?
Right.
But I really do think that I tell everyone, I'm like, it's just out of your hands. It's like, it's if that embryo is healthy and has the information there, it'll implant. But if you're having, and again, I see this a lot as second opinions. Okay, fine. One failed transfer or just a negative test or a chemical pregnancy. And your doctor's like, let's do the same thing again, fine. But really, if these are really good quality embryos, chromosomally screened, and you now have two unsuccessful transfers, just flat out negatives or chemicals, I really think it's time to explore, make sure there's not a dilated fallopian tube that we've missed. Make sure there isn't a clotting disorder or autoimmune condition. Make sure there isn't a polyp or a fibroid. So, fine, everyone's allowed to have one failed transfer, but really after two, if these are really good quality embryos, your doctor should be digging a little deeper.
That's so interesting. So patients, as you know, feel so out of control and they want to do something and they feel like so much of this is out of their hands. Are there things that they can do?
To be honest, like, I think you could do acupuncture, you could do various supplements, just try to focus on, being healthy, exercising, minimizing stress. But still, even then, I do think that there is an element of this that no matter how hard we try is out of our control. And I think that that is very, very, very hard thing to accept, right?
Yes.
Most
Yes.
things in life, right? You've got a test, you study hard for it, you get a good grade. You want to run a marathon, you go train, you run your marathon,
Right.
right? But this is one of those scenarios where, again, there's a small bucket of unexplained, even implant failures, right?
Yes.
You can't beat yourself up over it, right? Like it's like you have to take a step back, take a deep breath and say, I'm doing everything I can. Right. And I do think this is where it's really important for patients to seek the help of a mental health specialist, right?
Hmm.
Right. When,
Yes.
when it's just, they've been at it for years on their own, it's not happening. They come see me and it's still not happening right away. And now they start to go down this, they're unraveling a little bit. And I think this is where, right, there are people like you, Lisa, that their
Hmm.
entire careers are devoted to speaking to couples,
Busy.
individuals who are in a tough spot with this, right?
Yes.
And so I think
Yes.
it's really important that it's not a sign of weakness. It doesn't mean you're failing, but you need that person to help talk to you to keep you in the game, right? For me, the times that patients don't have success is when they give up, right? And
Yes.
so you just, you need that expert to who's been through, who's works with people every day in your shoes to really be by your side and just help keep you in the game.
Yes, 100%. And we know that people drop out because of stress, right?
Yeah.
That's so important. So I think, what you're bringing to light, Dr. Talebian, is something so important and what people don't think about very often, which is how they think about approaching treatment, because they first look on the internet for ideas, then they change their diet, then they change their lifestyle habits, then they change whatever else is going on. And if they're still not getting pregnant, then they come to see you. But by then, they may already be 40 years old, 45 years old. And then all of a sudden, it becomes a crisis for them.
Right. So I think, again, like, I don't know why there's this fear to come speak to me. Like, patients are, it's like so hard to get in the door. And I'm like, no, no, no. Like, actually, you'll feel better because you're trying to do this at home on your own and you're so confused and you're reading all these
Hmm.
things and you're doing all these, driving yourself crazy. Like, come speak to me. Like, let's get the data. Let's figure it out. So,
Yes.
generally, if you start trying to conceive, the guidelines, they always say, okay, if you're under 35, you got a full year. Okay, I'm going to tell you, if you're under 35, couple things. If your cycles are not regular, come in and see me
Right away.
immediately, right? If you're not having
Yes.
regular menstrual cycles, you need to see me immediately, right? None of this, oh, I stopped the pill and I'm waiting a year to see if I get my bleed back. No, like, you
Right.
need to see me more immediately. And even then, even I would say, if you're really under 35 and you've been having regular menstrual cycles and really 6 months has gone on, you should come in and do some testing. We may not necessarily jump into treatment, but at least come in and do some testing. Over 35, and based on the female's age, because we're born with our eggs, and so our egg quality shifts before men, before it does for men. But if you're over 35, it's really after 6 months. If you're not pregnant, come in and talk. And if you're over 40, it's kind of immediate. Like, start trying, but come
Hmm.
see us right away. Again, we don't have a ton of tests, right? It's some ultrasound, it's some hormone markers, it's checking the fallopian tubes, and it's a semen analysis. But that's it. It's pretty basic. We don't have a lot. But, come in and get the data. Let's figure it out. If there is something going on, the sooner we know, the better. But if you're frustrated, if you feel like you've been reading, you're doing everything right, you're, having timed intercourse at the right time, and you're still not pregnant, and now you're like going on the internet to be your own doctor, I'm like, well, just come in and let's figure this out. And there's all these like at-home tests now that people are doing. I'm like, you're already paying money for that. Just come in and see us and do a blood
Yes.
test or do the ultrasound, right?
Yes, 100%. And then you'll know, right? If you have PCOS or if there's some other issue, then they can address it and not just be wasting their time trying to get pregnant at home. I feel like even for the same-sex couples that I see they want to try at home for the lesbian couples, let's say, they're feeling like, well, my only issue is that I don't have sperm. Well, maybe, maybe not,
Right.
right? And how are they going to know unless they come see you first?
Right, right. And also for heterosexual couples, it's not always just the women. Like, right? Like sometimes the guy comes in and there's no sperm or low sperm counts, right?
Yes.
Another thing I've been seeing recently, speaking of no sperm, are men doing hormone therapy, taking testosterone,
Yes.
and it completely shuts down the sperm. There's no sperm in the ejaculate. And I'm not sure if whoever's prescribing them this hormone therapy, testosterone, is telling them that this will shut down their sperm production, but I've seen it recently a couple times.
Hmm.
And so that's another thing for any men listening, or women, for your male partners. Just make sure if they do have low testosterone, they should not be taking testosterone. They need to be taking Clomid or something that's going to drive their brain to produce more. But if you're taking testosterone, that tells your brain, I have testosterone in my system, and it completely shuts down the signals from your brain that tell the testicle to make sperm, and they have no sperm.
Yes, yeah. We had Colton Underwood on this podcast talking about that and how upset he was to discover that. And we see that these things happening. And even with the lesbian couples who have a friend who's a partner, and they say, we're just going to use an at
Right.
home sperm kit and we're going to try to get pregnant at home. We don't know what's in that sperm, right? And they don't know the genetics there either.
With that, it's like, okay, if you want to do it at home, just make sure everyone's done infectious disease testing ahead of time and make sure you've done your genetic recessive panels, right? To make sure that it's there's no
Good match.
crossover. Exactly. Right. I'm not
Yeah.
saying, okay, if it's a safe situation, just medically safe, then fine, try that a few times. But just you have to make sure you're protecting yourself both in terms of infectious disease and also for the genetic stuff.
Mm-hmm. And it's so difficult for patients for some reason to feel like I'm going to just take a beeline to my doctor, get all the testing done, and then know what I have to do. Everyone wants to take kind of the least invasive procedure first or try at home first. And that's a lovely idea, but it's not always effective. And it's very hard to think about that.
I feel like I see two extremes. I see the people coming in like, I want to know if I'm fertile and do all this testing, and then I'm going to start trying with my partner. And I'm like, well, actually, let's do genetic panels, great, but you don't really know until you start trying, right? We know that,
Mm-hmm.
right? So there
Mm-hmm.
are, I see like in New York, two extremes, like coming in a little not too early, but like hoping to find answers when they haven't started trying yet, and then the other extreme of like not wanting to come in and not do any testing. And, so either way, it's always, again, start trying. If not pregnant after a few months, yes, come in. Let's check the sperm. Let's check the tubes. Like, do the testing.
Right. Just don't wait too long, I guess,
Don't
is
wait too long.
the bottom line.
Yeah.
The
Don't wait
bottom
too long.
line.
Yeah,
The bottom line.
exactly. Because
Right.
it's not scary, right? Like just because you come in and see me doesn't mean we're going to be talking about IVF necessarily, right? I think people, and then there's also, I think, a lot of misconceptions about IVF, right? There's, people think that that's how you get multiples and that's how you have twins. And I'm like, no, that was IVF 20 years ago, right? That's not
Yes, right.
IVF
It's not
anymore.
the case.
Yeah.
Yes, it's true. They're more likely to have twins trying to get pregnant at home with a sperm kit
Yeah, and using if they're
and
if
using
they're
Clomid or something.
using Clomid, right? If they're,
Hmm.
exactly, like, right, if you've never really tried, and I see that too, like coming in, like, give me some Clomid, I'm going to go home and I'm going to try, and I'm like, but if you have never really tried, what, like, we're not giving you Clomid until you've been trying,
Hmm.
and you need Clomid, right?
And that's why everyone out here who's listening, it's really important to get your doctor's advice because you can see Dr. Talebian's giving us such wonderful guidance here. The other question I had, which people are very confused about, is what you alluded to earlier about the PGTA testing. If people are thinking about going through IVF or going through IVF, even with donor eggs, very often people might say, well, I have a young egg donor. Why should I bother doing that? What's your thought about that?
So PGTA, so let's explain, just backtrack. So that is doing IVF, growing a blastocyst, biopsying the blastocyst, and then freezing it. And the biopsy sample gets analyzed for chromosomes. So that's what PGTA aneuploidy stands for. There's PGTM, which is where the same exact process, but you're also analyzing the cells for a genetic condition, right? If egg and sperm
Mm-hmm.
stores
Mm-hmm.
carry cystic fibrosis, 25% chance the offspring get both mutations. So people sometimes go straight to IVF to avoid that and screen out in the embryo. So PGTA, I am in my practice a big advocate, almost exclusively PGTA across the board. And why, right? So
Mm-hmm.
I'm going to advocate for the technology that my lab is best at, right? I'm going to advocate for the technology that in my practice, in my clinic, gives me the highest live birth rate of a singleton healthy pregnancy. And for us at CCRM New York, that is PGTA testing our embryos, right? And again, as you know, Lisa, there's a whole history of IVF, right? When I first
Mm-hmm.
started practicing, that was not how I practiced, right?
No.
Because we were just going to blast culture. We were just learning or understanding PGTA testing, and freeze technology also has come a very long way. Let's not forget, right? We all talk about
Yes.
how egg freezing is a new technology, experimental until 10 years ago. But embryos, we used to freeze through slow freeze. And
Hmm.
now we vitrify them the same way we do eggs. Embryos, when I first started practicing in 2008, embryo survival rates with slow freeze were 75 to 80%. So you still lost, right? 20% freeze thaw. We didn't love to freeze. Vitrification, embryo survival rates are 99% at our clinic, right? So
Amazing.
huge history, right, of IVF and the progression of it. And again, I can advocate for the technology that at my clinic gives us the best rates. And that is everyone goes to blastocysts. And if you make a blast, it gets biopsied and frozen. And this can't translate to every clinic, right? Because it is dependent upon the ability of the lab to grow to
Mm.
blast, the embryologist's technique to do biopsy, the freeze and thaw, right? So people sometimes do second opinions with me from other parts of the country, and they're asking me what they should be doing at their local clinic. I'm very honest. I'm like, I can't really tell you because I don't know at your clinic what their blast rates are and how good they are at biopsy and freezing and what their PGT platform is that they use. Right. So, but for us here, primary ingredient, I always explain this to a healthy pregnancy is that the egg, 23 chromosomes with a single copy of each, the sperm 23 with a single copy of each, and they come together to result in a 46XX or 46XY embryo. That comes first and foremost, right? So if we have the technology to test the chromosomes of an embryo, which we do, to me, that is how do we get that embryo? That's the route. And yes, we know that in women, the risk of chromosomal anomalies increases across the board over the age of 35.
Yes.
Same for men. After the age of 50, the rate of chromosomal anomalies can increase as well. For men, 45 even, actually, some argue. More gradual, right? The
Yes.
chromosomal
Later.
decline in men is slightly later and much more gradual. For us, for the average woman, it starts really, the biggest drop off is 38 onwards, and it's very abrupt. And
Yes.
unfortunately, our diagnostic tools, also another area we need to work on, right? I don't have a blood test that I could offer a 32-year-old and assess what percentage of her eggs still function well or have good chromosomes and what don't, right? So even if they're under the age of 35 at our clinic, we still want to chromosomally screen because we want to identify that single embryo that has the highest chance of working. And if I have a younger patient under the age of 35 who does a cycle, who makes a lot, they have infertility, they're 30, 32, they've been trying for over a year, not pregnant or having chemicals. They, do maybe some IUI cycles, still not pregnant, and they do an IVF cycle. And a bulk of their eggs result in good embryos. That to me, tip off, red flag. There's something else going on here. It's
Mm.
not just the chromosomes. That to me screams inflammation, maybe endometriosis, maybe silent endometriosis. And then if I go ahead and put that one embryo in and they're still not pregnant, again, another big red flag, right? So in that scenario, the chromosomal, if I'm not testing the embryo and I'm just putting it in, is it the embryo or something else going on, right? So I just
Hmm.
think, it's really important data, right? Because if it's not working, what's going on here, right? When it works, great. We don't really look
Right.
backwards. But when it's not working, we want to learn. And why is it not working? Is it the embryo or is it something with the body, the environment? So even in the younger patients, I think the PGD testing is super helpful. And even from donor egg cycles, right? Like donor eggs can still result in trisomy 21 Down syndrome or trisomy 22. And it's not all the egg, there's the sperm component too, right? So
Hmm.
even in
Hmm.
those scenarios, I think PGT testing, again, that's our data here at CCRM New York. It gives us the best chance of success. And again, a fresh donor cycle, if it's a good cycle, they get really high number of blastocysts. And we know they're not all going to be chromosomally correct. So it just allows us to best select the single best one that should work.
That's so helpful because, as you know, we went from no PGT to PGT, and now many people are going back to no PGT. And there's so much controversy, but those are such great points, Dr. Talebian, because people don't often think about the sperm source and don't often think that they will be the small percentage of people, even in this young, 25-year-old's eggs who's going to have a problem, right? So everybody says, oh, well, she's 25. She's, her eggs are beautiful and the embryos are beautiful. There's going to be no problem. But you don't want to be that one person who's going to have this issue.
And again, particularly for donor cycles, you're freezing anyway, right? It's very rare nowadays that you're
Yes.
seeing the cycles that the
Right.
recipient is, the recipient has her lining ready and then we're going to do a fresh,
Right.
do a fresh transfer, right? That I don't think I've done since 2008, 2009,
A
right?
long time. Mm-hmm.
Right, a long time. But if you're going to freeze anyway, so some may argue that that little biopsy is going to damage that embryo. Again, if you're at a center with very skilled embryologists, that little biopsy should not be damaging the embryo or nominally decreasing its implant potential, nominally, right? So now
Mm-hmm.
you have a
Mm-hmm.
fresh donor cycle, you grow everything to blast, and maybe it's a great cycle and there's 8 blasts, so yes, and many of them could look, have the same morphology and the same grading, but we do PGT in these cases, and we do see that a couple of them, at least, 2 or 3 of 8 will come back with incorrect chromosomes. And so it just really allows that first transfer to work. But again, let's say we didn't test. We just did blast, we just froze at blast stage. And I do a transfer, negative pregnancy test. I'm like, okay, well, why? Is it the embryo or is it something now with the uterus?
Mm-hmm. Mm-hmm.
I don't have the answer, right? If it's a gorgeous embryo, donor, PGT tested, and it's a negative pregnancy test, red flag. And if that happens repetitively, we now know if these are tested embryos and it's happening repetitively, we've diagnosed some sort of uterine environmental problem. But if they're not tested and you now have 2 failed transfers or 3 failed transfers of untested embryos, I don't know. I can't really definitively tell you, was maybe one of them incorrect or 2 of them incorrect, and
Mm-hmm.
again, when it works, we don't look backwards. But when it's not working, we need a way to move forward, right? And so, and again, I see these cases because they see me, right? They do a year,
Mm-hmm.
pregnant, transfers, fresh or frozen, but not tested. And then they come see me a year later and they're
Mm-hmm.
like so frustrated, and I'm like, okay, well, we need to PGD test at baseline just so we can get the data. Is it embryo or is it something else going on? And then, let's think about endometriosis, right? It's a big one. I test a lot for it. When patients are failing transfers and I don't really have a reason, and a lot of them, but Dr. Talebian, I don't have any pelvic pain. I don't have the symptoms. I've read about endo. And I'm like, you know what? Endo is becoming this kind of more broad bucket term I use for just
Right.
pelvic inflammation. And
Yes. Or
it
any
presents
kind of scarring, right?
any scarring, any pelvic inflammation. It's not the same disease in everyone. It has so many different manifestations, but I do a lot of, it's a very hard diagnosis to make. The only way to really know if you have it is a laparoscopy and visualize it. But there are some screening tools for it. There's a uterine biopsy that we do called the receptiva. It's done a week after a natural ovulation and endometrial biopsy, and we send it off to a special lab that looks at a marker called BCL6. And if that is highly elevated, that may suggest inflammation and endometriosis, and that might be something to address before a transfer.
That's great. That's great information. So all of you out there, you can see how complicated all of this is, and you are not going to find these answers on social media. It's very important to make sure you get them from your doctor. We all want the best for you and we want you to get pregnant and have the healthiest babies that you can have. And it's really important to get the right advice from the right sources. So as we're winding down now, Dr. Talebian, is there anything else you feel that our listeners should know or any way that they can reach you?
I think I would say that, social media, the internet, like groups that are out there, fertility groups that patients have formed, I think it's use it to empower you, right? Use it to empower you, use it to kind of, hear what other people are doing at other places, but take it and then go speak to your doctor who knows your specifics in your case, right?
Mm-hmm.
Because it
Yes.
doesn't always translate. And, what worked for somebody may not work for you. But so I think, you want to use these platforms to your benefit and make, there's a community out there. There's other people in your situation too. But it's also not like they're not your doctors. You're not your own doctor, right? So just take that information and advocate for yourself. Go to your doctor, and it's okay to ask your doctor questions. It's okay, ask them questions, even if you're challenging them or questioning them. That's okay. You
Hmm.
should be doing that. You should be advocating for yourself because you want to go through this process knowing, without any guilt, not being like, I wish I had asked about this or I wish I had done that,
Yes.
right? Like, you
Yes.
want to feel comfortable and confident in your care, and you want to trust your team, and you should have that open dialogue with your doctor. And if you don't, if it's really not working out for you, I think it's worth kind of getting other opinions.
I agree wholeheartedly. And even to come for a consult, right? They don't need to engage in treatment, just to sit down and talk to you and ask you questions and get some sort of roadmap about what they should be doing is so worthwhile. It's a half an hour out of their day, and it could really change the course of their family building history.
And I get a lot of those consults. I think, at this point, um, I've been doing this for, right? Like I finished my fellowship in 2008. So I'm kind of at that point in my career where, yes, I'm not the oldest people out there, the most senior, but I've been doing it for a while and long enough that, I've seen a lot and I've learned a lot. And some of the things I think about today are not what I thought about when I first started practicing. Right. And so,
Mm,
yeah, but I think it's, take advantage of us. I'm not the only, there's a lot of us out there who have good experience, who have big hearts, will listen to you and, take advantage of us. It doesn't mean you have to necessarily switch care to us, but at least do a consult with us if you're stuck, if you're feeling stuck.
yes, yes. And how can people reach you, Dr. Talabian?
Absolutely. So
Mhm.
they could definitely, I guess, just call CCRM New York. I'm also happy to give out my email. It's my first initial last name at ccrmivf.com. I'm trying to get into social. It's like not my thing. I feel like I'm a little old with the social
That's okay.
thing, but but yeah. Anyway, reach out to me, email me. At least I could give, we can put my email out there also.
Okay, so we can put the contact information for
Yeah, absolutely. Yeah,
CCRMY in the show
but
notes.
also my direct email, I'm happy to share.
Thank you. That's very generous of you. And we really appreciate your time today and all your sage advice and your big heart and really caring so much for your patients and about them having the best journey possible. So thank you for your time.
And thank you, Lisa, also for supporting our patients and supporting all the individuals and people out there on this journey. You and your colleagues are critical. And I thank you so much.
Thank you. It's always my pleasure. And for all of you, thank you for joining us. We really appreciate you being here. And please subscribe because it's how we keep going. And I will see you next time.
Bye. Thank you.
Hi, it's Lisa Schumann. I hope that you enjoyed that video and I hope it helped you. And if it did, please give us a thumbs up and subscribe because that's how we keep going. It's really important to us. And if you liked it, you might like this one.